My name is Paddy Barrett. I'm a cardiologist. I work in Dublin in the Black Clinic, but I have spent the last several years wandering around the globe, doing a variety of different roles, and worked with different institutions around the world. I've worked, as I like to say, as like the Baz Luhrmann song about sunscreen. I've lived in New York City once and left before it made me hard, and lived in Southern California once, but left before it made me soft. So that was my time in Scripps and in Colombia. But I've collaborated and had my kind of work in various different institutions: Time Health, New York Academy of Sciences, Headspace, and an opportunity also to work with NASA testing devices. So really, that has been kind of my experience. But fundamentally, kind of, it's about heart disease prevention when we actually look at making the biggest difference here. So that's what I really want to laser focus in on. For anyone who are interested, I've written a short book last year, which is available where all good books are sold, or even bad books like this one. And you can check that out. And also, I have a free weekly newsletter that goes out once a week on Saturday mornings. And that's covering all topics related to the content that we're going to talk about here. It's all on living longer, kind of lifespan, health span, and soul span. So thinking about how you're going to spend your time. So what I'm going to focus on primarily is the idea of heart disease prevention. And some of you here will be interested in preventing heart disease for the very first time. And there will also be people here who have heart disease or who've had issues in the past, like stents or bypasses, heart failure, etc. But the principles really are all the same. So this isn't just for people who've never developed coronary disease or heart disease in any way, shape, or form. This applies across all the domains in terms of how we focus on prevention. So what I want to try and get across are a set of principles that people can take away here and then apply in their own lives, or think about in terms of how it applies to them. So let's see here. So what we're going to do is there's really an infinite amount of things that we could focus on in terms of doing this talk. But what I wanted to try and do was focus on 7 different areas to give you kind of key takeaways that you could learn from. The first is that when we think about prevention, it's probably technically incorrect to describe it as prevention. And we have to think about this as setting the odds in our favor. So we never really prevent a lot of major chronic diseases. We only delay them to much later in life. And if you understand that, it's all about setting the odds up to try and get that right, or setting the odds up to say, if you've had a heart attack in the past, to set the odds up so you don't have a second one or another one thereafter. And so it's all about understanding this as an odds-based game. In terms of understanding what heart disease is, we typically describe it as heart disease, but you need to understand what heart disease actually is, and then the difference between heart disease and, say, a heart attack. And so this is the difference between the disease of plaque in your coronary arteries versus the event, which is a heart attack. And there's important differences between those two entities and how we actually approach preventing them over time. The third thing we'll talk about are the idea of risk factors that actually increase the likelihood of the development of plaque, but also the likelihood of an occurrence like a heart attack or a stroke, and understanding that there's a hierarchy of risk factors that we focus on, and trying to focus on those first in terms of reducing risk. We're going to understand the role of cholesterol. Sometimes this can be a little bit confusing in terms of our current landscape, so we'll try and add some clarity around that. I'm going to mention a genetic cholesterol disorder that's super common, that about 10 to 20% of the population have. It's called Lp(a), and we'll go into that a little bit more and link these all together. We're going to talk on very briefly on kind of some of the common vices, salt and alcohol. Kind of often people have lots of different questions about this. We're going to talk about high blood pressure, what it is and how to think about it. We're going to talk about exercise and then try and link all of these together. And then at the end, I'm happy to take any questions that people may have. So fundamentally, this is a game of odds. And the way I try and think about this is that the whole process is about keeping the odds on your side. Now, whether you like it or not, the game is on, and no one gets to choose if they play, but they're already in, and they're all in with the most valuable thing that they have, which is your life. So that's why I think it's so important to get this right. But we have to remember that we can seriously tilt the odds in our favor. We can never guarantee that we're going to prevent heart disease or prevent a heart attack or prevent a stroke, but we can try and tilt the odds as much as possible in our favor. So there are people who do everything right and can still have a bad outcome. But in general, the people who do things right or put the odds in their favor with all the different opportunities that we have generally do much better over time. So we have to think about this as a game of odds. Now, one of the most important takeaways when we're thinking about not just heart disease, but about living longer, is that if we look at causes of death in general as kind of broad categories, and we think about things like injuries and communicable diseases, which are things like infections, for example, worldwide, these only make up about 10% of all deaths. 90% of all deaths in the developed world are from what are called non-communicable diseases, or these are chronic diseases that you will often kind of hear described as heart disease, cancer, dementia, etc. And these are the big conditions that we're actually trying to focus on. So again, if we're making bets here and looking at this as an odds-based process, it's focusing on primarily non-communicable diseases or chronic diseases. When we look at global deaths in 2019, you can see that cardiovascular disease kills a huge amount of people, and cancer kills about half that. And that's for all of the world, both developing and developed world. Now, I've included some other statistics here just to kind of put the impact of heart disease in context. A lot of the time in the news, you're going to hear about natural disasters. But in terms of what is actually causing people's deaths, heart disease by far and away is the leading cause of death. The similar picture in Europe, when you include all the European states, heart disease is the leading cause of death. When you concentrate just say on Ireland, the UK, etc., it's much closer in terms of heart disease and cancer kind of overall. And again, just to put some context in terms of where we're looking at other deaths. And so really the elephant in the room here is heart disease when we're thinking about the leading cause of death and how we go about trying to reduce the impact of that again. So it's again all about looking at this on kind of an odds basis. We know from decades of research that about 80 to 90% of early heart disease is preventable. And what's crucial to point out there is that we say early heart disease. So that's heart disease at a younger age, because the truth is that everyone in life starts off with no plaque in their coronary arteries, but over a long enough time horizon, everyone will develop plaque in their coronary arteries. So the question is not, will I ever develop coronary disease? It's really about when, but we know that if you tilt the odds in your favor, you can get it very much later in life. So it's less of an issue for you over that time frame. And the key to this is based, again, on decades of research, that there's a formula that we can apply in terms of how we look at the inputs that increase the probability of the development of plaque in the coronary arteries, and also the likelihood of things like heart attacks, etc. And the other really big takeaway here is that if you use cardiovascular disease or heart disease as your wedge, you say, listen, I'm going to try and optimize cardiovascular disease. We've really great research to say that if you get that right, you get health right in general, in terms of you tend to have a lower incidence of certain cancers, lower incidence of dementia, and lots of other major chronic diseases. So if you get heart disease right, you tend to get everything else right. So there's a big added benefit in terms of using the metrics of heart health to actually get benefits across a whole load of different disease states. Now, when we look at the aspiration for most people at around age 50, we look at a thing called all-cause mortality. And all-cause mortality is effectively the chances of dying from anything. So it's not discriminating in terms of types of death, but in general where kind of most of the deaths are actually made up. And if you look at people at age 50 who don't smoke or physically active, who have a healthy diet and are kind of meeting all of those criteria, you can see that kind of for females, they're, who meet none of these criteria, they're living another 29 years, so to about 79 years of age. As you add on each healthy lifestyle factor, you can see the average increase in lifespan. For males, you can see here, getting none of these factors right at age 50, they generally live another 26 years. But as you add on each additional healthy lifestyle factor, you can see a significant increase in the average life expectancy after age 50. So the goal really for people by age 50 is that you should be hitting these metrics. But in general, if you're hitting these metrics at any time point or convert to these metrics at any time point, you're going to be accruing benefit in terms of reducing your risk. So it's really important. You have to say, where I am, what are my aspirations, what am I trying to do, and looking at these metrics and say, am I hitting these metrics, or is there a way that I can hit these metrics? And we know that if you actually put all of this together, that you can increase your odds. The second thing to point out is that we talk about heart disease as really kind of a condition, but heart disease isn't a condition per se, it's a category. So it's an umbrella term that captures lots of different things. So there'll be people who are on this call who've had, say, coronary artery disease, needed a stent, for example, and that's atherosclerosis, that's plaque in the coronary arteries. There'll be people here who have irregular heart rhythms like atrial fibrillation or valvular disorders. But when we actually look at heart disease in general, we can broadly categorize it into coronary artery disease. So that's plaque in the coronary arteries, stroke, and then other in terms of things like heart failure and other irregular heart rhythms, for example. So stroke and the other heart conditions make up about 20% of all heart disease, whereas about 80% of heart disease is made up of coronary artery disease. And if we look at coronary artery disease, so that's plaque in the arteries of the heart, and stroke, that is primarily made up of atherosclerosis. And atherosclerosis is the technical term for plaque in the coronary arteries. So if we know that heart disease is the leading cause of death, if we know that 80 to 90% of it is preventable, and if we know that atherosclerosis or plaque in the coronary arteries makes up the lion's share of heart disease, we know that this is the area that we need to understand the most. And this is the area that we need to actually de-risk ourselves over time. And so it's not to discount the importance of these other conditions. But again, if you're looking at this on an odds basis, we have to look at this in terms of where is the biggest gains likely to be made. So atherosclerosis as a technical term, it's, that's why we use heart disease as a stand-in kind of term. Atherosclerosis doesn't exactly roll off the tongue. But what you're looking at here is the natural life cycle of everyone's arteries. So everyone, when they are born and kind of very early in life, has a normal, clean coronary artery with no evidence of plaque accumulation. Over time, you start to accumulate what are called fatty streaks. So these are the earliest deposits of plaque accumulation in the coronary arteries. They convert to fibrofatty plaques and then ultimately start to build up as advanced plaques. And we have evidence going back decades that even these early stages of fatty streaks and fibrofatty plaques are identifiable in people even in their teenage years. So this process starts very, very early. And this emphasizes why we need to start very early also in terms of addressing it. You can see here an example of atherosclerosis, and this is the specimen of the aorta, the main blood vessel in the heart, and also the coronary arteries. But fundamentally, you have blood flow that runs down an artery. Cholesterol particles are spherical particles that travel in your bloodstream, and they generally go in and out of the artery wall. What happens is sometimes they go into the wall and do not come back out, and your body then decides to consume them and leaves a residual deposit. And that residual deposit in the artery wall is atherosclerosis. So it's not that the lining of the inside of the artery gets furred up like a pipe that we use in terms of the plumbing analogy. It roughly equates to it, but it actually, what happens is a cholesterol particle goes into the artery wall and becomes stuck there and kind of builds up as a plaque. What happens then is that if you look at the actual artery wall, it first starts to move outwards. So even when plaque is accumulating, if you look inside the coronary artery, say with a coronary angiogram, you will see zero evidence of plaque accumulation or narrowing of that plaque. When it kind of finally exceeds its capacity to do that, it starts to move inwards and then slowly starts to accumulate as plaque until it gets to a point where it will potentially reduce the blood flow down that artery. So in terms of understanding this process, we always have to understand where everyone is on this trajectory from normal vessel to potentially advanced plaque, given a long enough time horizon. If we think about what causes a cholesterol particle to cross over the artery wall and become stuck, in simple terms, if you have more of them, that's high cholesterol. There's an increased probability that a particle will get stuck. If you have small, dense particles, there's an increased probability that they will cross over. And small, dense particles are seen most commonly in diabetes, for example. Or if there's damage to the artery wall, it just makes it much more likely that any particles will cross over and become stuck in the artery wall, building up as plaque. Now, heart disease as a process occurs over decades. But heart attacks happen suddenly. And this is often the confusing part for people, is that someone may present with a heart attack rather suddenly, but the truth is that they had been building up heart disease probably for many, many years in advance, but were just unaware of it. Because what a heart attack is when you take that advanced plaque and it ruptures. And so think of it like a blister that ruptures, and a clot forms in the artery and then subsequently stops blood flow down the artery to supply the heart muscle. And that is what a heart attack is. So just because you have heart disease doesn't necessarily mean that you will have a heart attack. But the more heart disease that you have, or atherosclerosis, the higher the risk of a heart attack. And we have to kind of always use this as the thing that we want to prevent the most. But the easiest way of preventing it is having less amount of that plaque in the first place. So the scary thing is that for many patients, the first symptom of heart disease is sudden cardiac death. This is the classic scenario of someone who does a stress test and they're told it's all fine, and then they have a heart attack and die the following week. The reality is stress tests are to identify very narrowed coronary arteries, but don't tell you whether or not you have plaque. And so any plaque, in essence, can rupture. So it's important to try and avoid the amount of plaque as much as possible. And the majority of plaque ruptures happen from plaques that are not obstructive, so not seriously narrowing the coronary artery. So therefore, people generally don't have symptoms like chest pain or shortness of breath. And this is why relying on things like symptoms is a very bad strategy in terms of identifying your heart disease risk. And where we have to look at other factors like risk factors, etc. And so if you actually look at the studies who die of people who die suddenly from heart disease, so this is somewhat of a technical graph, you can see that the majority of patients who die suddenly from heart disease had no symptoms prior and then did not have obstructive plaque. So this just kind of, to them, came out of the blue. But in reality, heart attacks happen suddenly, but heart disease happens very slowly over time. And so we can identify that. Now, my objective for myself and for all of my patients is that they get to the end of a very long and happy life and die with coronary artery disease rather than from coronary artery disease. Because even if you do everything right in terms of optimizing all of your risk factors over a long enough time horizon, you will eventually develop some plaque. But again, the idea here is to die with coronary artery disease rather than from it, and that is eminently possible. So if we're trying to avoid this endpoint, we know that it is led to by a chronic disease, but chronic diseases are led to by risk factors. And so the analogy that we'll make here is that high blood pressure is a risk factor that increases the risk of a disease, which is coronary artery disease, which increases the risk of a heart attack. And traditionally, in terms of how we have approached this problem, is that we have waited for patients to present with coronary artery disease, with plaque in the coronary arteries, with heart attacks, needing stents or bypasses. And then we have kind of aggressively managed their conditions. Whereas we know that we really need to move the emphasis from simply managing coronary artery disease to managing the risk factors that lead to the coronary artery disease in the first place. Now, that may not be possible for everybody here, but the goal is always the same. Even if you have coronary artery disease, have had a heart attack in the past, managing blood pressure reduces the likelihood of it progressing and the event happening like a heart attack again in the future. So managing risk factors is key. You have to think about this as a continuum in terms of risk factors leading to disease, leading to event. And so we're always talking about prevention of the next step in the pathway. And so if there ain't no plaque, there ain't no heart attack. So how we think about risk factors impacting risk is that it isn't a linear equation. Risk doesn't just build up kind of on a kind of one-to-one scale. If we look at risks on the bottom here, smoking, diabetes, hypertension is the HTN, ApoB is cholesterol, and then 1, 2, 3 is adding them together, or all four. OBS is basically obesity, and PS is physical sedentary, so being inactive. Having one of these risk factors, you can see, increases your odds of a chance of a heart attack by about twofold, which is significant. What's important to point out here is the vertical axis is not a linear axis, it's exponential. So it doesn't just go up on a kind of an additional scale. If you have all three, your risk now goes up 13-fold. All four goes up 40-fold. You add in obesity, it goes up another 60 times. And then you can see thereon and so forth, the risk just goes up and up and up. So this is why it is so important to actually tackle these risk factors to de-risk yourself by the same amount. And we know that about 9 factors explain about 90% of the risk for both males and females. And this is why we know that about 80 to 90% of heart disease in its early form is preventable. Now, the important thing to point out here is that not all risk is created equal. So we talk about lots of different risk factors for heart disease: smoking, high blood pressure, diabetes, inactivity, etc. But when you try and rank order these in terms of the ones that actually drive the biggest risk, there is a hierarchy that exists here. If you compare people who are going to develop coronary disease and you look at the risk factors that ultimately led to their development of coronary disease and the likelihood of that impact, having type 2 diabetes, as you can see, is a huge impact on your cardiovascular risk. This is a huge, huge problem because if you look at the obesity epidemic that is currently worldwide, the obesity elements are significantly increasing the likelihood of people developing type 2 diabetes. So even compared to things like hypertension, which is high blood pressure, you can see here that it causes a big issue. Now, you will see that obesity is a big risk factor for heart disease, but the big issue is when you have obesity and the metabolic consequences that go with it, such as type 2 diabetes, etc. This is in a study of basically 45-year-old individuals followed for 20 years, so somewhat reflective of the time course of people in midlife moving on over a 20-year time horizon. We know that the specific risk factors in terms of rather than diseases, LPIR is basically insulin resistance, which is a precursor state to diabetes. So again, we're seeing this metabolic consequence of excess weight being a major driver of risk. And then other factors are also significantly at play, things like LDL cholesterol markers and inflammatory markers. But there is a hierarchy to how we look at these risk factors, and it's important that we address these. And what's really encouraging is particularly for those metabolic risk factors like insulin resistance and diabetes and metabolic syndrome, they're most effectively managed in terms of with lifestyle factors, getting them right over time in terms of a really strong emphasis on nutrition and exercise. I also want to touch on a genetic type of cholesterol that many of you will have not heard of before, but is super common. And on balance, about 10 to 20% of the people on this call have an elevated Lp(a). And Lp(a) is a type of cholesterol that is super common and that loads of people who have it, but they just don't know that they have it. And when I hear the story of my dad had a heart attack at 50, his dad had a heart attack at 50, their brother had a heart attack at 50, this is the genetic cholesterol disorder that I am thinking about. And you're going to probably hear an awful lot more of this in the future. We know that 10 to 20% of the population have an elevated Lp(a). It is the most common genetic cholesterol disorder, genetic cholesterol particle disorder, and it significantly increases the risk of coronary artery disease. So that's the atherosclerosis in the heart arteries, increases the risk of a heart attack, of stroke, peripheral vascular disease. So that is that atherosclerosis plaque buildup in the leg arteries, but also calcification of the aortic valve that makes it kind of much less likely to open properly and ultimately may need a surgical procedure to fix. So this is super common and driving up a lot of risk for people, and it's often not tested, which is frustrating. Now, if you look at the risk that Lp(a) actually confers in terms of the risk of heart disease in the future, if you take young adults and you follow them for about 20 years, you can see their risk is about 2.5 times higher. And the average age which they start to develop heart disease is about 47 years of age. So again, anyone with a very early family history of heart disease in terms of a genetic sense, this is the first thing that we're often actually looking at. And even you can have an elevated Lp(a), so it's a type of cholesterol in the setting of a normal LDL or kind of quote unquote bad cholesterol. And the risk again is about 2.5 times as high. Now, in terms of the cutoffs for these, we kind of have different units, but generally greater than 30 milligrams per deciliter or 75 nanomoles. It only ever needs to be measured once in your life. And the important thing to point out here is that there are currently no approved therapies to lower Lp(a). And I use the word approved quite carefully here because that is very much likely to change in the future. There are therapies that can lower it by about 80 to 90%, but they are currently in phase 3 trials, and those phase 3 trials we should know the results of those this year, but it's likely that they're to be positive, and so therefore we will have a treatment option. And the fact that we have had no approved therapy option for this is often why Lp(a) is not tested. But what I would always point out about this is just because you can't lower Lp(a) doesn't mean that you can't reduce cardiovascular risk. So that's a really important distinction. You may have that risk factor, but if you have other risk factors, You can manage those and your overall cardiovascular risk can be reduced. So that's an important point that we need to make. And how we reduce that risk is using every other tool available to us, and that we optimize all the traditional risk factors. We're really strict around blood pressure control. We're really strict around lipid control. We're really strict about getting people to do the things that they need to do from a lifestyle perspective, like exercise and nutrition, optimizing sleep and stress. And we know that for every significant increase in Lp(a), we can offset it by being even more aggressive about our cholesterol targets. So yes, there is no dedicated therapy, but we can significantly reduce risk. Now, we'll move on to talking about blood pressure. And blood pressure is one of these areas that I think causes, again, a lot of confusion, but it doesn't have to. And when we think about normal blood pressure, there's no specific number that we would categorize as normal or abnormal. But broadly, a top number, systolic number greater than 140 is considered elevated, and less than a systolic of 120, which is the top number, is considered normal. But there's the whole range in between, and the risk increases proportionately as you go up. And you have to think about blood pressure on a range basis. We know that the Semane tribe in Bolivia, who are kind of the tribe that have the least amount of heart disease in the world, that if you look at all adults up to 80 years of age, their average blood pressure is about 120 millimeters of mercury. And if you only look at people up to age 60 years of age, their average blood pressure is only about 112 millimeters of mercury. And this is thought to be one of the major factors as to why this particular tribe has the lowest rates of heart disease in the world. And so if this is something that we can apply to that population, it's something that we should all try and aspire to ourselves. Now, we know based on this is US data, but it applies to most developed nations, is that almost half of all adults have high blood pressure. And we know that as a risk factor, it is the risk factor associated with the greatest amounts of early death. So this is something that we really need to be mindful of measuring, and it's often undiagnosed and untreated. It's something you can simply measure yourself at home with a home blood pressure monitor and take some average readings over time to really understand, is high blood pressure an issue for you? As I mentioned, it's the risk factor associated with the most deaths worldwide, which is really unfortunate because a lot of the time, as I said, it's missed, and a lot of the time we don't do a good job at actually treating it. We know that for every 20 millimeter increase in systolic blood pressure, the top number that you measure, the risk of a heart attack or death, a heart attack or stroke actually doubles. The good news about that is that this also works in inverse. With the right lifestyle changes, you can pull that right back down, and the risk that comes with it comes right back down with it. So if you look at the things that actually make a big difference here, yes, we know medications will make a big difference, but lifestyle factors will be the core approach to how we actually reduce risk or preventing it happen in the first place. In general, in populations in the Western world, as someone gets older, their overall blood pressure is likely to increase. We know that's a natural pattern for most people who live in the Western developed world. But if you actually look at the people overall and then stratify them by their degree of physical fitness, we know the people who have high physical fitness tend to get that rise in their blood pressure much later in life. Even a moderate level of physical fitness tends to delay the onset of higher blood pressure readings, and having low physical fitness tends to mean that you have higher blood pressure readings. We know that in interventional trials, so these are kind of the best trials that we have, even 120 minutes per week of aerobic exercise over a 3-month time horizon can result in significant reductions in blood pressure. So about 7 on the top number, 5 on the bottom number. And this was really only a 3-month intervention trial. And if we think about doing this over a lifetime, and this doesn't have to be high intensity exercise in a gym, kind of all covered in sweat. This is just being active and trying to push yourself more within your scope of what you're able to do. And in general, we see significant reductions in blood pressure. We know that when it comes to lowering blood pressure, for every 1 kilogram of weight loss, your blood pressure drops by approximately 1 millimeter in the top number. So losing 10 kilograms, for example, can make a huge difference to your blood pressure and also the risk that comes with it, which is why we try and prioritize that as much as possible. And I have many patients who have made kind of big efforts here and have come off all of their blood pressure medications in terms of approaching this as a problem that is driving their high blood pressure. We know that alcohol consumption is directly related to high blood pressure, but the key thing to point out here about alcohol consumption is that The biggest amount of risk in terms of driving up high blood pressure is for the highest amounts of alcohol consumption. For people who drink very small amounts of alcohol over, say, a weekly basis, the impact on their risk of heart disease and high blood pressure, for example, is quite small. So recently you would have seen a lot of things potentially in the news in terms of talking about the risk of alcohol and potentially kind of banning it or kind of putting very significant labels. And all of this comes down to the phrase, the doseth maketh the poison. And so if you're someone who has, 1 or 2 drinks a week, or if ever, the incremental risk that you have is likely to be very, very small. But if you're drinking substantial amounts over a weekly basis, the risk is the most. And we know that in terms of lowering blood pressure, the greatest effects in terms of alcohol are for those who drink a substantial amount, cutting back substantially, rather than for people who drink maybe once or twice a week and then basically cut that out entirely. The impact on blood pressure is likely to be very modest. So when you see any of the literature on this, we know that in general, there's no amount of alcohol that has been proven safe for you. So this idea of alcohol or red wine being good for your heart is just not true. That's based on research that it really has not ever really panned out to be the case. So there's no amount of alcohol that is good for you. But that is not to say that a very small amount of alcohol is going to be very, very bad for you. Certainly on the same line, if you're drinking a substantial amount of alcohol. So everything has to be put in context. And again, you're looking at odds here. So kind of how are you stacking the odds in your favor in terms of approaching this problem? The salt question around high blood pressure comes up all the time. And, there isn't a week that goes by that there isn't something conflicting on the newspapers that actually say salt is good or salt is bad. And the reality is it's somewhere in the middle. We know that very high levels of salt consumption are known causes of high blood pressure, but some people are much more salt sensitive than others. And that is something that has become quite clear in the literature over the last few years. So in general, if you're looking to reduce salt in your food, many people will say, well, I don't actually add any salt to my food. But if you look at salt intake in populations, the majority of your salt intake will come from the foods that you eat that is already included in those foods, and most likely coming from processed foods. So processed foods typically contain very high amounts of salt, and over kind of a weekly period, you can see that your salt intake can be very high. So if you're considering using this as a strategy for lowering high blood pressure, what I would generally advocate is that you do a trial of reducing salt intake in your diet. So you measure your blood pressures, you go and look at your salt intake, you reduce it as much as possible. And then what you see is, has it made a difference to my high blood pressure readings? And if it makes a big, big difference, that's fantastic. You now know that you have a lever that you can pull to reduce your risk. But if it's not making a huge difference, then you have to ask what the utility of that is. So you really have to assess the response. But we know that about 73% of people will have some degree of response. So for most people, this will work to a degree. And the majority of those individuals will get a reduction in the blood pressure of about 5 millimeters of mercury, which is significant. The other key point here is that salt is primarily made up of sodium and potassium-based salts, but predominantly sodium salts. And if you look at trials of people who were given 25% potassium salts that you can buy in most supermarkets or online, you can see when those individuals were given potassium-based salts compared to just purely sodium-based salts, there was actually significant reductions in blood pressure. But more importantly, not only was their blood pressure reduced, but their risk of stroke was reduced by about 14%. And there was a 12% reduction in the risk of dying from any cause. So if you're not reducing salt, think about substituting in a potassium-based salt for any of the salts that you add to your food. But that isn't going to make a difference to our primary source of salt intake, which is processed foods. Another big factor in terms of blood pressure is going to be a condition called insulin resistance. And insulin resistance is really, it sounds technical, but in truth, it's just a precursor state to diabetes. And it's something that we can identify years in advance. And so that means that although your blood sugar levels may not be going up, we can measure what are called insulin levels. And as they go up, you can see that your blood pressure starts to go up. And so this is where when people have any of the features of metabolic syndrome, so that's high blood pressure and a large waist circumference, and this is where kind of a lot of the excess weight becomes kind of an issue. And we also know that weight loss actually makes a big difference here in terms of reducing insulin levels. The second thing we need to point out here is thinking about what your target blood pressure should be. Now, this has been somewhat of a movable target over the years, but it is really important that we get this right. And we've somewhat circled in on the kind of the exact target for most people. Now, what's important here is that you get to your target blood pressure. And ideally, we will get there with lifestyle measures, with making the changes that we've talked about so far, with making the modifications to our exercise and nutrition or any of the things that we're taking. But if medications are necessary, medications are necessary. And what matters most is less so how you get there, but more so that you get there. So it's outcome over process here, but ideally with lifestyle, but if necessary, with medications. And if we think about what our target blood pressures are, so if you have high blood pressure, say a systolic of 150, and you're put on a medication, it's really important that you follow up on that to see that you actually have gotten down to your target. So it's not just a matter of just putting someone on a blood pressure medication and then that risk goes away. What matters is that you've gone on the blood pressure medication, an adequate amount or dose, and that you've gotten to target. And for most people, the target blood pressure for most people is ideally in the low 120 systolics, averaged out over time, and ideally with lifestyle, but with medications as needed. Now, for some people, they won't tolerate low blood pressures like that, particularly if you've had very high blood pressure for a long time, or if you're kind of older in terms of you may not be as tolerant to that. So not everyone will get down to there, but for most people, low 120s is the target, and we're less stringent in somewhat older people. Lastly, what I want to talk about is exercise. And exercise is hard because it requires a significant amount of input in terms of the effort that you have to make. But the benefit that you get from it is phenomenal. And if you're looking at probably the single best thing you can do for preventing heart disease, preventing major chronic diseases, for living longer, is really focusing on the amount of activity that you're doing on a weekly basis. This is where we have probably the greatest evidence in terms of promoting longevity over time. Of course, it is one of the factors that we look at, but its impact on all the different risk factors that we've talked about is just immense in terms of the literature and research that we have on this. Now, when I talk about exercise, for some people that will mean running marathons, but for most people, it's really simply about activity. It's the amount of activity that you do. And if we look at step count research, we can see that as you go above 6,000 to 7,000 steps per day, the reduction in the chances of dying from any condition over a 10-year period starts to reduce significantly. They reduce the most at around kind of the 10 to 15,000 steps. And that's not to say that you have to be hitting up at 15,000 steps. But in general, if we look at people who are hitting that 7 to 10,000 steps per day target, there's about a 50 to 70% lower chance of dying from any cause over a 10-year period compared to people who are hitting very low step counts on an average daily basis. So this is one of the most kind of simple interventions that almost everyone can do and hit that target, but it just requires the time and effort to actually do it. But the payoff is quite substantial. If we look at, again, all-cause mortality, so that is the chances of dying from anything. So not just heart disease, but including cancers and dementias and all these other kind of conditions. We know that compared to 4,000 steps per day, taking 8,000 steps per day halves your chances of dying from anything over a 10-year time frame, and taking 12,000 steps per day reduces it by about 65%. So the bang for buck here is absolutely incredible. If we look at fitness markers, so this is VO2 max in terms of a measure of aerobic fitness, you can see that there's a very straight line. Higher the degree of fitness, the lower the chances of dying from any condition over, say, a 10-year time frame. Now, no one's going to live forever. And the reality is it just decreases the odds of the onset of a major chronic disease, which is the thing that is actually conferring the benefit and the mortality benefit. So VO2 max is a target that people can have measured. There's ways to simply measure it at home by doing what's called a Cooper test. You go out and run for 12 minutes and put your figures into a calculator, or else you can measure it with a gas exchange in a kind of formal lab setting. But if you look at VO2 max and stratify a population, so these are not kind of elite athletes, just as a regular population, and you compare the people in the top 2.5% versus the bottom 25%, they're 5 times more likely to live longer than those in the bottom 25%. But even the low versus high, there's a 4-fold difference. And the low versus above average, nearly a 3-fold difference. So it's not that you have to be an elite athlete. You just have to try and move up the scale. And the real benefit comes from getting off zero in terms of activity levels and also improving your aerobic fitness and getting that benefit that comes with it. In terms of how we go about improving VO2 max and improving aerobic fitness, the lion's share of the work is done in low intensity exercise. So that's basically any activity like walking fast, cycling at a slower pace is just building up all of that activity. The other activities like very high intensity exercise where people are kind of covered in sweat and doing all that kind of stuff, it has its place, but it actually occupies a much smaller percentage of what is required to do that. But we also have to balance that with the needs for things like resistance training and focusing on balance and flexibility, because we know that these components also together, when you combine them with aerobic training, confer the greatest benefits, not only for the prevention of chronic diseases and preventing heart disease, but increasing health span. So that is your ability to do the things that you want to do later in life. And that is just as important as lifespan. So some people will say, listen, do I really need to do those high intensity exercises? If you look at the elite athletes, so Eliud Kipchoge, who can run a sub 2-hour marathon, does the majority of his training in those lower zones. So that is just getting your heart rate up a little bit, but not having to go too crazy high. So there is benefit that is possible from all of those approaches. In general, we just need lots of movement. So if you're bamboozled by things like VO2 max and all these different things, it's just movement, more and more and more and more movement, and not getting too caught up in the actual technical details. But the technical details are put across to really illustrate the bang for buck that is there in terms of prevention of not just heart disease, but all major chronic diseases. So what we'll cover here today are kind of 7 key things. Number 1, you have to look at this as a game of odds. You're always trying to tilt the odds as much as possible in your favor. We know that if you live long enough, you will eventually develop coronary disease. But if you get the inputs right at the start that we talked about, you can tilt the odds of developing it later in life. So therefore, decreasing the odds of something like an event, like a heart attack. We know that there is a distinct difference between heart disease and heart attacks. And in general, the less heart disease, the less risk for a heart attack. And the goal for all of us, myself included, is to live a long and healthy life and die with coronary artery disease rather than from coronary artery disease. We have to understand that there are key risk factors that increase the risk of heart disease over time. All risk factors are important, but the key things of diabetes, for example, and metabolic syndrome are really overshadowing lots of the other historical risk factors like smoking, which have kind of fallen off in terms of their prevalence. We know that cholesterol, as a principle, the development of atherosclerosis or plaque in the coronary arteries is fundamentally to do with the retention of a cholesterol particle. So you want less of them, and you want them to be less damaged, and you want less damage to the artery wall. We know that Lp(a) is a very common genetic cause of early heart disease. So for people with early heart disease and in the family, and that story of kind of dad having a heart attack at 50 and his brother having a heart attack at 50, this is often the first thing that I am looking for. We touched on things like salt and alcohol, that there's not exactly a very specific yes-no answer to these questions, and that largely the dosage make it the poison, and often it requires a little bit of trial and error over time. In terms of high blood pressure, you have to know what your numbers are, and you have to know that you're actually getting down to your target with the interventions that you're using, whether they be lifestyle interventions or they are medications. And lastly, if you were looking for one major takeaway from all of this, and there was one lever that you were going to look at pulling the hardest, exercise is going to give you the biggest bang for buck. in terms of prevention of diseases, but also in terms of increasing your health span, which is the ability for you to be able to do the things that you want to do for as long as possible in life. So they are kind of 7 key principles that I think everyone can take away and apply in their own life. And that applies to whether you've never had heart disease, whether you're young and looking to invest in kind of a lifetime reduction, or if you're older and you already have heart disease, about decreasing the chances of this progressing or the recurrence of another event.